Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everybody. I wish you a Ramadan Mubarak and happy Eid. Today we will talk about the last group of drugs which are used in treatment of hypertension, which are the diuretics. Generally, the diuretics are drugs which can increase the excretion of water and electrolytes, and they have many clinical applications other than the hypertension. They are used, for example, in the treatment of congestive heart failure, as we will see later. They are also used in treatment of pulmonary edema, for example, in renal edema. They are used in hypertension and in cases where urine output is low or what's known as oliguria. So what are the main goals of today's presentation? It will be slightly long presentation because we will talk about all indications of diuretics and side effects as well. So today, inshallah, we'll talk about the physiology of the nephron, to make a quick revision about the physiology of the nephron. Then we'll talk about what are the different types of diuretics and where they act, what are the site of action of these drugs. Then we'll talk about the individual diuretic, including the mechanism of action and the indication and contraindication and other clinical applications. So we start first with the general revision about the physiology of the nephron. And as we know, the nephron is composed. The nephron is the unit structure of the kidney, where all the function of the kidney takes place. It is composed, as we know, from the glomerulus and several tubules, including the proximal tubule. This is the proximal tubule. Then the descending and ascending lobe of Henle. Then the distal tubule and the collecting tubule. Of course, as we know and we studied in physiology, the nephron is concerned with three main functions. The first function is the filtration. The first function of the nephron is filtration, and filtration usually takes place for all components in the plasma, except of course the plasma protein, and this is done usually passively through the glomerulus. Okay, so everything in the blood will be filtrated except the plasma protein will be filtrated through the glomerulus. This is the first function of the nephron, filtration. The second is the secretion. Secretion, as we have said, it takes place in the proximal tubule, and this takes place for weak acids and bases and some electrolytes. And also, secretion takes place in the collecting ducts in this area, in the collecting ducts. In this case, this happens, secretion takes place for the ammonium ions, hydrogen ion, and potassium ion mostly. You have the secretion of ammonium ions, hydrogen ion, and potassium from blood to the urinary filtrate takes place in the collecting ducts. The third function of the kidney is the reabsorption. Everything, as we said, in the blood is either filtrated, except of course the plasma protein. They are either filtrated or actively secreted. And mostly everything in the urinary filtrate will be reabsorbed. This reabsorption takes place at different sites of the tubules. As we said, proximal tubule is the place of reabsorption of sodium, chloride, potassium, water, and mostly all glucose and amino acid present in the proximal tubule are reabsorbed. In the thick ascending lobe of Henle, mostly sodium, potassium, and calcium, about 20%, 25%, which is present in the urinary filtrate, they are absorbed in the thick ascending lobe of Henle. The same thing in the distal tubule, reabsorption of many electrolytes takes place, especially what is left of sodium, magnesium, and calcium in the urinary filtrate. So this is generally the main, we have to know the main parts of the nephron, what's the classification, what's the main function of each part of the tubule, okay? So this is first very quick revision of the physiology of the nephron. Second, we'll talk about what are the sites of action of diuretics, where they act. So the first group, which are known as carbonic anhydrase inhibitors, and the most famous example is acetazolamide, which is the prototype. This group, they act at the proximal tubule. They act at the proximal tubule, and we will know how they act there. The second group, which are known as osmotic diuretics, and the prototype is mannitol. They act as well on the proximal tubule and as well on the collecting ducts. So mannitol, osmotic diuretic, they act at two places, at the proximal tubule and at the collecting ducts. The third group, they are known as loop diuretics, and the prototype is furosemide, very famous loop diuretics. They act at the thick ascending loop of Henle. Thick ascending loop of Henle. This is the third group. The fourth group we are going to talk about are the diazide diuretics, like hydrochlorothiazide, the prototype, and many other examples. And these they act at the distal part of the nephron. They act at distal convoluted tubules. Okay. Last group we will talk about are the potassium-sparing diuretics. And most famous prototype is spironolactone. These drugs, they act at the collecting tubules. So we know now the site of action. We'll talk about each group of diuretic and their action and indication and contraindication as well. So the first group we are going to talk about, inshallah, are the carbonic anhydrase inhibitor. As we know, this enzyme, carbonic anhydrase, this is an enzyme present in different places in the body. It is present, for example, in the nephron, and it is also present in the eye and present in the choroid plexus, which produces cerebrospinal fluid. So these drugs, once they inhibit carbonic anhydrase inhibitors, once they inhibit the enzyme carbonic anhydrase, they do that in the three places mentioned. So what are the most famous examples? Most famous examples is the acetazolamide, which is the prototype carbonic anhydrase inhibitor. We never forget acetazolamide. And the other amides like dichlorphenamide, and metazolamide. As you can see from their name, they are sulfonamides. They are in structure, they are sulfonamides. Because they are sulfonamides, you expect that they will produce allergic reaction, as we will see later, okay? Other groups are dorozolamide, or brinzolamide. These two, they are sulfonamides, but they are used only topically in treatment of glaucoma, and we will talk about that in details, okay? So these drugs, they act by inhibiting carbonic anhydrase at different places in the body. We'll start with the first place, which is the carbonic anhydrase, which is present in the renal tubules. They act specifically, if we look at the proximal convoluted tubule, at the proximal convoluted tubule. So just if we see at the proximal convoluted tubule, we can see this is the epithelial cell of the tubule, epithelial cell, epithelial cover, and this is the luminal side where urine flow, urinary filtrate, this side. The other side is the interstitium, blood interstitium, which is the capillaries which blood flows through them. Okay, so usually in the proximal convoluted tubule, as we have said, many reabsorption takes place. For example, as we have said, all sugar is reabsorbed passively through the proximal convoluted tubule from the urinary filtrate into the general circulation. Amino acid as well, and other electrolytes. 70% of the sodium is reabsorbed from the urinary filtrate into the general circulation in the proximal convoluted tubule. How this happens? Usually sodium ions and chloride ions, of course, sodium chloride will be ionized into sodium ions and chloride ions. The sodium ions will be exchanged with the Broughton or hydrogen ion on the luminal membrane by an exchanger known as sodium Broughton exchanger. This is known as sodium Broughton exchanger. It is present in luminal membrane. This is a passive process. It takes place without utilization of energy. Okay, so 70% of the sodium which is present in the urinary filtrate will be reabsorbed by exchange of a proton. Where the proton, this is inside the cell, so proton will be exchanged for sodium. Where the proton comes from, we will know that in a few minutes. Okay, now once sodium is inside the cell, it will be reabsorbed into the general circulation by exchange with potassium using the sodium-potassium ATPase or sodium-potassium pump. Okay, now so most of the sodium will be reabsorbed and it will be pumped back into the general circulation into blood using the sodium-potassium ATPase. Potassium, of course, will leak into the urine. Potassium, in this case, the excess potassium will leak into the urine. Okay, so this is what happens. Chloride will be the same thing, will be exchanged with a base, and then inside the cell, chloride will pass into the general circulation through channels. So this is what happens with sodium. What happens with bicarbonate? Bicarbonate actually, they cannot penetrate the luminal membrane. They cannot penetrate the luminal membrane. The reason, I don't know why, maybe because of its size. There is no passive diffusion of the bicarbonate through the luminal membrane. It cannot penetrate it. So what will happen in this case? How it is reabsorbed? We have said that most of the bicarbonate is reabsorbed in the proximal tubule. How this happens? Usually, so bicarbonate, which is present in the urinary filtrate, it binds with the proton, which is the hydrogen atom, which is exchanged for sodium, as we have said. This binding will result in what's known as carbonic acid. Carbonic acid. Okay. Now, this carbonic acid, it's still in the urinary filtrate. Well, what will happen to it? This carbonic acid will be dehydrated by carbonic anhydrase. This carbonic anhydrase enzyme is present in luminal side of the epithelial cells. It is present in luminal side of the epithelial cells. So what does it do? It will dehydrate carbonic acid. Carbonic acid will be dehydrated. It will give us water and carbon dioxide. Of course, water and carbon dioxide, they are diffuses passively into the epithelial cells of the proximal convoluted tubule. Okay, so water and carbon dioxide passively will diffuse into the cell. Once carbon dioxide and water it is inside the cell, what will happen to it? It will be acted upon. It will be hydrated. It will be acted upon by the same enzyme, by carbonic anhydrase, to give us back carbonic acid. To give us back carbonic acid. Then what will happen to carbonic acid? It will be ionized to give us bicarbonate and hydrogen ion. So in carbonic acid, last step, it will be ionized into bicarbonate and hydrogen. As you can see, bicarbonate was outside in the urinary filtrate. Now it is inside the cell in the proximal convoluted tubule. What will happen to it then? There is a specific carrier on the membrane exchanger, specific carrier on the basolateral membrane of the cell. This is the basolateral membrane. There is specific carrier which carries bicarbonate into the general circulation. Now we know how bicarbonate is transported into the general circulation. Okay, it is process, very delicate process, and this is continuous all over your lifetime, which is really it is إعجاز إلهي سبحان الله. Okay, now so as we can see, one hydrogen atom can lead to reabsorption of one molecule of sodium and one molecule of bicarbonate. Okay, so now this what happens. Well, this is the normal physiology, what happens in the proximal convoluted tubule. So what these drugs do, the carbonic anhydrase inhibitors, what they do? We said that they inhibit the carbonic anhydrase. They inhibit the carbonic anhydrase. So they will inhibit the conversion of carbonic acid to water and carbon dioxide. That means they will prevent reabsorption of bicarbonate. So this is one. Also, they will prevent reabsorption of sodium. Why? Because sodium, as you know, depends on the presence of proton. If there is no proton as a product of carbonic anhydrase ionization, that means there is no reabsorption of sodium. So carbonic anhydrase inhibitors will prevent reabsorption of sodium and will prevent reabsorption of chloride and as well will prevent reabsorption of bicarbonate. This will result in certain physiological action. Therefore, acetazolamide, a carbonic anhydrase, will result first in increased excretion of sodium and water, which produces diuresis. This is why. This is one. This is one. You have these drugs, they inhibit the carbonic anhydrase, they prevent the reabsorption of sodium and water, of course, because increases molarity of the urinary filtrate will take with it water. So this produce diuresis. This diuresis usually it is short-lived, not of long period of time, maybe days. It's short-lived. Why? Why? Because the sodium, which is not absorbed here in the proximal tubule and the bicarbonate as well, it will be reabsorbed at more distal part of the nephron. So by time diuresis will be lost. So when they are used as diuretics, acetazolamide, when it is used as a diuretic, it is used in certain cases when they are used in certain cases when there is metabolic alkalosis, where there is metabolic alkalosis. So usually they are used as diuretic in endemic conditions where there is metabolic alkalosis. Why? Because these drugs, as we have said, they will increase the excretion of bicarbonate. Okay, so this is the first clinical application. They are used as short-term diuretics in treatment of edema, especially accompanied by metabolic alkalosis. Okay. Next, they will inhibit bicarbonate reabsorption. That means bicarbonate, as we know, it is an alkaline. Bicarbonate is an alkaline. So in this case, they will make the urine alkaline. The urine will become alkaline. That means the pH of the urine will be high. They will be high. This has certain clinical application. This has certain clinical application. The first application, as we have said, they are used in certain cases of metabolic alkalosis. What does it mean, metabolic alkalosis? That means the pH of the blood is high, is not neutral. The pH of the blood is high, towards high levels. It is known as metabolic alkalosis, as it happens in many cases, as we will mention later. So in this case, acetazolamide can decrease the metabolic alkalosis by increasing the excretion of bicarbonate. Second application is to increase the excretion of acids, especially uric acid, because acids in alkaline urine, they will be soluble, as we have mentioned before several times. Acids in alkaline will be ionized. If they are ionized, that means they cannot be absorbed. And as well, they will be soluble, therefore they will be soluble in water, of course, and they will be excreted. Therefore, this is application. They are used, acetazolamide, they are given in cases of hyperuricemia, because they will increase the excretion of uric acid. In this case, they are given with bicarbonate because after a certain doses, the depletion of bicarbonate will take place. So usually the acetazolamide is given as a supplement with bicarbonate to increase the excretion of uric acid. Okay, so this is another application. A third action, which results from alkaline urine, is it will prevent ammonia excretion. To prevent ammonia excretion. As we know, ammonia is a product of the liver, and in certain hepatic impairment, when there is hepatic impairment, especially with people with heart failure, usually they secrete a large amount of ammonia. Ammonia in the urine, they will be ionized as ammonium ions, and ammonium ions, they are polar, they will be excreted in the urine. Okay? But in case of alkaline urine, if the urine is alkaline, ammonia will not be ionized, will not be ammonium ions. It will become non-polar. Once it becomes non-polar, it means that they can cross the biological membrane, and therefore they will be reabsorbed back into the general circulation. Reabsorption. This reabsorption will result in what's known as hyperammonemia. Hyperammonemia. Hyperammonemia is very dangerous because it can cause hepatic encephalopathy, and this will result in liver failure. Okay, so acetazolamide in this case and its congress or its like, they should never be given to people who are suffering from impairment of liver function and with heart failure. Why? What is the reason? Because these people usually they produce large amount of ammonia, which is secreted in the urinary filtrate by glomerular filtration. Inside the urinary filtrate, ammonia will be ionized into ammonium ions, and ammonium ions, they are ionizable and will be excreted. If the alkaline is urine, ammonia will not be ionized, it will stay non-polar, and therefore it will be reabsorbed back into the general circulation. This will result in hyperammonemia, and hyperammonemia can lead to liver function disease. Okay, can lead to hepatic encephalopathy or liver failure. Okay, so they are contraindicated. Of course, we know that calcium, which is secreted in the urine as well, calcium, will be precipitated in alkaline urine. Calcium as anion, which is secreted by glomerular filtration, calcium will be precipitated in alkaline urine. This will result in renal stone, calcium renal stone. Therefore, long-term use of acetazolamide can lead to calcium renal stone. Why? Because calcium will be precipitated in alkaline urine. Okay? So this is the first group, a carbonic anhydrase and their effect on the renal tubule. Second, we'll see the effect inhibition of carbonic anhydrase in the choroid plexus and the ciliary muscles of the eye. In the choroid plexus, as we know, this is responsible for the production of cerebrospinal fluid. Usually, for choroid plexus, carbonic anhydrase is responsible for the production for the secretion of bicarbonate into cerebral spinal fluid. So what will happen if we inhibit the carbonic anhydrase? We inhibit the secretion of bicarbonate in the cerebral spinal fluid, and this will result in decrease in the cerebral spinal fluid production. Okay, so this is applied clinically in cases of what's known acute mountain sickness, acute mountain sickness. And some people who climb mountains, who like climb mountains, sometimes what they do fast ascending above 3,000 meters. This fast ascending will lead to cerebral and pulmonary edema, because of the increase in production of cerebrospinal fluid. So in this case, these people will take acetazolamide as a prophylaxis to prevent acute mountain sickness. Okay, so this is the first application. Second application, and the ciliary muscle, as well the ciliary muscle of the eye, which as we said before, they are responsible for the production of the aqueous humor, and usually the bicarbonate increase the volume of the aqueous humor. And this bicarbonate secretion into the aqueous humor depends on the carbonic anhydrase. Therefore, if we inhibit carbonic anhydrase, we'll decrease the production of aqueous humor in the eye. As we have said before, decreasing aqueous production inside the eye, especially posterior chamber, this will result in decrease intraocular pressure, and therefore they are used in treatment of glaucoma. Okay, by inhibition of carbonic anhydrase from the ciliary muscle. By inhibition of carbonic anhydrase in the ciliary muscle, we decrease aqueous humor production, and this will decrease in intraocular pressure, and therefore these drugs are used in treatment of glaucoma. Most famous, which is given orally, especially acetazolamide, can be given orally in this case in treatment of certain types of glaucoma, especially in open-angle glaucoma. And there are local carbonic anhydrase inhibitor like dorzolamide. Dorzolamide is only given locally but as eye drops. Okay, so these are the information related to carbonic anhydrase. So carbonic anhydrase is present in the urinary filtrate, inhibition of which will result in several actions, including diuresis and etc. Inhibition of carbonic anhydrase in the choroid plexus will decrease production of cerebrospinal fluid, and this is applied in cases of mountain sickness. Also, we said carbonic anhydrase is responsible for the aqueous humor production, and this can be inhibited, and it is used in treatment of glaucoma. Okay, so this is the first group, which are the carbonic anhydrase inhibitors, and they have very important clinical application. I would like to thank you very much for your attention. Excuse me for this rather long presentation, but I hope that you enjoyed listening to it as I have enjoyed giving it. Please don't forget to subscribe to my channel. I wish you good luck. I wish you happy Ramadan and happy Eid Fitr Mubarak alaykum jami'an. Thank you very much. Wassalamu alaikum wa rahmatullah wa barakatuh.